It's your turn.
Thank you so much. It gives me great pleasure to talk about something I'm so passionate about, and we've been working for almost 3 decades. I'll begin with a story, again from Chennai, December 26th, 2000, and it was 2004. So this is the kind of devastation that happened in tsunami. And some of these pictures are so iconic and so blood-curdling that you don't know the extent of damage that could have possibly happened. And at that point of time, I was at St. Stephen's Hospital, and we got a call from a group of people there who had just a medicine box. And there was a nurse there, and they wanted to help. That's all. And the entire project started, and we connected to a doctor there, and the doctor was able to reach that place. He managed to bring his own BP apparatus and a glucometer, and they arranged an ECG machine from a broken down laboratory there. So they had just this amount of data with them, this amount of equipment with them, and they had a camera, of course. And then they went out, and there was this Rescue Foundation NGO which connected with us, and we set up the first actual initiative for telemedicine. I was part of that, where we had a whole control room in St. Stephen's Hospital, the big auditorium there. I mean, if you compared to the smartphones you have now, that we can imagine it was almost 3 times this size of the room, and the kind of equipment that we had there was mind-blowing. The entire conference hall was locked up, and we had generators going on 24/7 kind of thing, connectivity. We had ISRO had come in to a small extent, but actually what worked, because there was no connectivity there, what worked was a 144 kbps connection, which they managed to get on a dial-up network on a mobile phone. Intermittently we used to get it, but ultimately they managed to get a continuous swing. So that was the story of the first initiative we did in 2004, December 2004. And starting from there, this story began. And we decided to go on to do Tele Ophthalmology. We were one of the 6 partners, along with Shankar Netralaya, IIT Kanpur, to have with the Director General Health Services, to do a pilot study in telemedicine targeted primarily towards tele ophthalmology. So now the program highlights was basically to create a network of care, to create a database of visual function and eye-related disorders in the given area, and identify those areas that can use the network for care, and to enable a directed, cost-effective measure to alleviate causes of low vision, to establish simultaneously the telemedicine model, to establish a minimum acceptable standard of care for telemedicine. Here we're not talking even of teleophthalmology, basically talking of telemedicine, and to develop continual methods of internal validation and documentation, so as to be able to keep it, basically all teleophthalmology initiatives were like North Indian weddings. At that point of time, the 1 year that we had an experience of was like North Indian weddings. You would have a big thing going on, and at the end of it, everything would just go. So there would be nothing left for the community to look back into. And what we needed was a 24/7/365 kind of a care, which would give a holistic empowerment as well as care for the community, and initiate a unit development rather than just give telemedicine. So the model that we were working with, as against, there were 2-3 models that people were working with. They were working with the bus model. We worked with this model that we were working with, was basically, we have a village slum which caters for a population of 3,000 to 5,000, where we have a vision supervisor. So this was basically a vision supervisor. We called him the Netra Rakshak. This is subsequent to a Netra Rakshak program. We had a Netra Rakshak program with the WHO, where we trained supervisors in the periphery, and they would be marked people in this community, and anybody with any kind of vision problem would be referred to this person, and this person would follow up any intervention that is being done, and also follow up CBR, that is community-based rehabilitation, for patients who did not have avoidable blindness. I mean, who probably required mobility training or some other kind of occupational therapy. This person would be responsible for that. Then there was an MLOP, or a middle level ophthalmic personnel, or ophthalmic technician, a vision practitioner, one of those vision technician, and they would look after a population of about 20 to 50,000 in a vision center. And you had a mobile van which would connect these two as well as the base hospital, so as to be able to communicate with everything. And the base hospital, of course, was taking care of was the apex place, and we would have intermittent surveys and internal validation camps to be able to see that the thing was working. So this was the responsibility of the Netra Rakshak. So just screen and register a patient. Any patient with any kind of visual complaints, any kind of structural complaints, any kind of sensory problems, they would be referred, and they would be referred to either the MLOP in the vision center or to the mobile van, depending on the schedule that was there. And of course, as I said, they ensuring compliance for intervention, contact for emergency situations, and community-based rehabilitation. That was a very important arm, which was primarily missing in most of these areas in the periphery. And be responsible for maintenance of the village data. So at any given point of time, we would be able to pick up the data and say, so many people requiring care. So example of the person on the left is a vision Rakshak and Netra Rakshak, and we have an MLOP who's come on a visit to this place. Basically just take very gross pictures. You have a cataract on the right, you have two patients with cataract. It's all sent by the Netra Rakshaks. And you have clefting syndrome. As much, they can have this girl with the clefting syndrome who was referred to the base hospital because of this. And this was with the traumatic coloboma of the lid. So now, in the vision center, basically was slightly upgraded, like most vision centers are, but they would have equipment that would be able to screen and provide us images in a far more greater detail. So maybe even look at the fundus and send to us. And so the MLOP here was responsible for compilation and data management right across all the villages that was under him. So, a little more detailed things like, this GFS with cataract, patients with a contracted socket, a person with, these kind of problems, as well as. So now here we basically anything more, and to ensure that the continuity of care was available, we had a mobile van which was manned by a middle-level ophthalmic personnel and a driver. It had a slit lamp, a camera with zoom. It had a fundus camera, and at that, this project that was done is basically dating back to 2006. So we did not have Remedio with the fundus on phone at that point of time. So we had to innovate as we went along. Most of the software that was used was homegrown, something which everybody could use. So we made software for them which was difficult for them to comprehend. So we brought it down to an Excel spreadsheet where they would just get it. And double encryption was done at the base hospital so that both at the periphery and at the center there would be no, there's some kind of data privacy that was ensured. So now this is a picture from 2006, a mobile van there with a slit lamp attached and a fundus camera which was, made using a camcorder and a high lens which is attached in the front. So the networks we were working in, there were many networks, but the network we used for the study purposes was in Bagpat with basically 3 vision centers and a multiple of sub-centers and about 27 Netra Rakshaks in function. So basically, this is cost effective. Our idea of this was to ensure a continuation of care, and we in that current year we screened about 54,000 people, patients, and cost per screening was 18.66 rupees, just 18.66 rupees with community participation. The community contribution amount was about 2.56 and the program contribution was 16.10. So this was per screening that was done. So it was a very low cost community participation. As you go along, we improved and we realized that the recurring costs were as low as 40 paisa, so it's still going on. So now additional activities that we could do through this net was a process of empowerment which included women empowerment. We had very interesting stories. I mean, we had a village where the women knew nothing. So they said, why don't you make masalas? So we got masalas done, and there was another person in another community who decided to open up a shop for them. So we had a masala making entrepreneur in one side and a person who sold the masalas in the other village. There was a concept of dividing, all through the net, soya making, the technology was given, toy making, child-to-child programs, study groups, so much so that when the network was free, they were using it to support their children for homework. They needed a maths teacher who was available somewhere else. He had actually gave tuitions across the net. So it was amazing. And, de-addiction, there were child-to-child support groups who actually worked with de-addiction because there was a lot of, in the community, there was a lot of drugs which had become a problem among teenagers. So there was a lot of the support group which was playing a part through the thing. And special interest groups. They had actually got together and made a football team in Bagpat just because they had the thing. Then Kisan clubs, microfinance, and peer group support. So whenever they needed loans, they would not take loans from banks. They would just support each other and do it. And the bottleneck was the energy because they used to get electricity once a week in Bagpat. So we needed to give them something. I devised a pedal power generator, very interesting concept, where we had 4 households using one pedal power generator, pedaling for 15 minutes. Each person would come for 15 minutes, and they would get power for about 2 hours. So for 4 of them would get power for 2 hours, and that was good enough from 6 to about 8 to 9 o'clock. They would have their light, and they would also use that for the telemedicine for purposes. Solar power, of course. Then I remember, there was a lot of organic farming training going on along with NABARD. So we used to actually give them, worms. In the assurance, it used to be given free to these Netra Rakshaks to be distributed in the community, where the only condition was that at the end of 3 months, they would give back 1 kilo of worms, so to be given to the next village. So a vermicompost and organic farming going on there. Technical know-how for, jugards, particularly driven by women, so women empowerment. E-chopals, human resource sharing, to be jobs, other things, that kind of things actually started out through this network that we had for the community, by the community. So it was, some photographs, this is the vermicompost thing, and this is very interesting ophthalmoscope that you have there on the top, where we attached a very small button camera, the spy camera, to be able to take a picture like a direct ophthalmoscope. And this is another one, similar kind of a image device using a 90D, which we used to, those days when we did not have the Remedio funders on phone. So these were some of the equipment that we do. We had a lot of innovations at that point of time. This is, of course, very interesting. I'm sure none of you have seen this. This is where the worms were put and the vermicompost is prepared. And the 3-layer thing that was done. So thank you so much. Thank you.
Yeah, that was a wonderful exposition about how you started from a calamity, the positive aspects of that. I should not say positive, but that calamity made you think and move positively in such direction that you try to help them in their visual aspects as well as also bring them empowerment, especially the women empowerment, and making the community thrive by themselves for their own welfare. So that was a very commendable project that you have taken up, and you have succeeded in your project. So it was a very nice exposition. Thank you.